So good afternoon. So the topic that has been given to us is all about the prostate problem and the erectile dysfunction. So let's move on with the overview of these two diseases. So prostate problem. So the prostate is a small gland located below the bladder and in front of the rectum, which surrounds the urethra. And it played a crucial role in the male reproductive system, which produces fluid that nourishes and transport sperm. So, however, various causes that can cause prostate problem can also cause discomfort and can lead to potential complications. So, under prostate problems, we have here three diseases. We have the prostatitis, the benign prostatic hyperplasia, and the prostate cancer. So, prostatitis refers to the inflammation of the prostate gland, and the benign prostatic hyperplasia is referring to the enlargement of the prostate gland. And the prostate cancer is referring to a commonly cancer that occurs with men in aging. So, under prostatitis, there are two types of prostatitis. This is the acute bacterial prostatitis and the chronic bacterial prostatitis. So the other disease is the erectile dysfunction, which is also known as the impotence, which refers to the inability to achieve or maintain an erection sufficient for satisfactory sexual performance, which would be further discussed by the following group members.
Okay, so for clinical manifestations of prostatitis, we have pain or burning sensation when urinating. This is due to the inflammation of the prostate gland that is causing discomfort when urinating. And other manifestation is difficulty urinating, such as dribbling or hesitant urination. This is due to the urinary tract muscles is weakened, that is caused by the enlargement of the prostate gland, causing painful urination. And frequent urination, particularly at night. We also have cloudy urine and blood in the urine. And then we have fever, chills, muscle aches, and other flu-like symptoms. So if there is infection, it will manifest fever, chills, and muscle aches. And for the etiology, we have the cause of prostatitis depends on whether you have chronic prostatitis or bacterial prostatitis. So if you have a UTI, you may be more likely to get bacterial infections. So UTI prone to bacterial prostatitis. If you have nerve damage in your lower urinary tract or have emotional stress, you may be more likely to get chronic prostatitis. Other causes may include chemicals in your urine, your body responds to a previous urinary tract infection, and most of the time, doctors don't find any infection in men with chronic prostatitis. Therefore, diagnostics performed will be digital rectal exam, urine test, blood test, and prostatic specimen test, and then urodynamic test and imaging to diagnose the following disease.
So we have here the pathophysiology of prostatitis. So the first stage is the phage preparation. So before there will be prostatitis, there must be a host. There must be a leaking cause. So we have here the intrarectal administration. So this means that bacteria or the contributory factors for the prostatitis may be caused. It may be from the rectal due to the lymphatic systems of the body, and the bacteria that migrates from the urethra into the prostate. So with that said, there will be antibacterial and anti-inflammatory action. So it might be the antibacterial medications prescribed. So if it will be a successful, if it will be a successful treatment, it will be so the next thing is that eradication of that infection and the reduction of the prostate volume, increase in the maximum urinary flow rate. And if it will be a failure, the next is the selection of new phage, cocktail or a continuous antibiotic treatment.
So we move on to the medical intervention of first one is antibiotic agent, specifically fluoroquinolones. Fluoroquinolones are some example is levofloxacin. Prostatitis is caused by a bacteria. So next one is continuous therapy with low dose antibiotic agent may be used. And the next one is anti-inflammatory if the patient is febrile and has normal urinalysis. You may also use alpha adrenergic blocker therapy such as tamasulosin may be prescribed to promote bladder and prostate relaxation. We move on to the nursing management. So first one is to administer the prescribed antibiotic agent and provide comfort measures, including prescribing analgesic agent and CPAP. The second one is to educate the patient about the importance of complying antibiotic therapy. The third one is to encourage the patient to avoid foods and liquids with diuretic action such as alcohol, caffeine, and tea. Advise also the patient to avoid any sexual activity during period of acute inflammation. Next one is to encourage the patient to avoid sitting for long periods, and also remain patient on their medical follow-up for at least 6 months to 1 year. We move on to benign prostatic hyperplasia. Prostatic benign hyperplasia is a non-cancerous enlargement of the prostate. It is one of the most common disease in aging men. It causes bothersome lower urinary tract symptoms that affect quality of life by interfering with normal daily activity and sleep pattern. So, benign prostatic hyperplasia is common in men age older than 40 years old.
So we have here the pathophysiology of BPH or the benign prostatic hyperplasia. So the first here is the due to etiological factors, but according to studies, the causes of BPH is idiopathic, or the doctors do not know the main cause of the BPH. But there are contributory factors for the BPH. So the first here is the changes in male hormones level in older men, aging, inflammation due to bacterial invasion, and fibrosis may play a role in causing BPH. So after the due to etiological factors, we have the enlarged nodule tissues of the prostate gland due to the etiological factors. And after that, if the enlarged nodule tissue, it will compress the urethra. And if there is compression of the urethra, it will lead to obstruction of the urethra. So the urine from the urinary bladder, it will be stuck. It will be stuck on the urinary bladder, and it will cause calculus formation and inflammation, and leading to hypertrophy of the bladder muscle. So we have here the clinical manifestation.
So the clinical manifestations for benign prostatic hyperplasia includes urinary frequency, urgency, nocturia, hesitancy, and in starting urination. When we say nocturia, it is the urgency of a patient to wake up at night in order to urinate in a regular basis, and decrease in or intermittent force of stream, sensation of incomplete bladder emptying, and abdominal straining with urination. When intermittent or urine retention and large residual volume occurs, it can lead to azotemia, which is the accumulation of nitrogenous waste products and can lead to kidney failure. The other generalized symptoms includes fatigue and anorexia, nausea and vomiting, and pelvic discomfort. For the etiology, the doctors do not know the exact cause of benign prostatic hyperplasia, but changes in male hormone levels and aging, inflammation, and fibrosis may also play a role in causing benign prostatic hyperplasia. So for the diagnostic test, including the physical examination, which focuses on the health history of the patient, which also includes the patient's family history, past surgical history of relating to prostate and others. Medical tests, urinalysis to screen hematuria or UTI, a prostate-specific antigen blood test, and for invasive procedures, if there are indicated invasive therapies needed, urodynamic tests, cystoscopy, transrectal ultrasound, and biopsy are included in the diagnostic testing.
So next is the medical management. Treatment depends on the severity of the symptoms or the causes of the disease. Catheterization is applied if a patient are not able to void, and cystostomy is also applied to provide urinary drainage. And we can also give alpha-adrenergic blocker. Example dito is yung terazosin to relax the smooth muscle of the bladder, neck, and the prostate. We can also give alpha reductase inhibitor to use to prevent the conversion of testosterone to DHT and decrease prostate size. So we go on to cancer of the prostate. Cancer of the prostate is the most common cancer in men, but yung symptoms niya hindi mo makikita at early stage. Among men diagnosed with prostate cancer, 98% survive at least 5 years, and 84% survive at least 10 years, and 56% survive 15 years. So prostate cancer is common sa US and Western Europe. For the clinical manifestation, this includes the difficulty starting urination, weak or interrupted flow of urine, urinating often, especially at night, trouble emptying the bladder completely, loss of hunger, loss of weight, bone pain, pain or burning during urination, and blood in the urine or semen, pain in the back, hip, or pelvic that doesn't go away, and painful ejaculation.
Let's now go to the pathophysiology of prostate cancer. So, in here, there is normal prostate epithelium at first, and under this, proliferative inflammatory atrophy, there is now carcinogens, and in that carcinogens, there is genetic alterations, meaning there is genomic damage. And under this proliferative inflammatory atrophy, there is localized prostate cancer. Meron na po siyang prostate cancer. There is cytokine receptor interaction, meaning there is apoptosis. It is apoptosis, meaning there is programmed cell death, and this leads to cellular migration, invasion, cell proliferation, or circumstances for cell survival. And under this localized prostate cancer, it will now go more severe to metastatic prostate cancer, meaning it spreads to different organs. And in this metastatic prostate cancer, there is cell proliferation, and under this is androgen independent. The final stage of this cancer is androgen independent, or meaning it cannot be treated. There is no treatment for this. And let's now go to diagnostic test.
Okay, so for the diagnostic test, we're going to undergo blood test, digital rectal examination, biopsy, staging and grading, and Gleason score. Then for the medical management, we can do non-surgical or surgical. For non-surgical, this approach include actively monitoring the course of disease and intervene only if the cancer progress or if the symptoms warrant further intervention. And for the surgical intervention, pwede natin gawin yung radical prostatectomy. This is a complete surgical removal of the prostate, seminal vesicle, tip of vas deferens, and often the surrounding of the fat, nerve, and blood vessel. So,
Next is the erectile dysfunction. As said earlier on the overview, erectile dysfunction is the inability to maintain erect penis or orgasm. So it is also known as the impotence to or inability to achieve or maintain an erection sufficient for satisfactory to sexual performance. So it is common condition, can significantly impact the man's self-confidence. So there are two causes of the erectile dysfunction. First is the physical, caused by physical. So there is a long list here. So first is the heart disease, clogged blood vessels, also known as the atherosclerosis, diabetes, obesity, and increased hypertension. And we have here the certain medications, tobacco use or smoking, and sleep disorders, and low testosterone. So that's the physical causes of the erectile dysfunction, and we have here the causes for the under the psychological. So brain plays a key role in triggering the series of physical events that causes an erection, starting with feelings of sexual excitement. So under psychological, we have here the conditions, depression, anxiety, and other mental health conditions or problems, and relationship problems due to stress, poor communication, and other concerns. So we have here the clinical manifestations for erectile dysfunction. So the common clinical manifestation is the trouble achieving or maintaining an erection. That's the inability to maintain an erection, and decreased sexual desire, difficulty achieving orgasm, signs of depression or anxiety, low self-esteem, and relationship problems. So we have here the pathophysiology of erectile dysfunction.
Let's go now to the pathophysiology of erectile dysfunction. So here, there are two differentiation, or there are two leading causes of this, which is cytogenic erectile dysfunction and organic erectile dysfunction, as stated earlier by Mr. Janaban. Let's now go first to the cytogenic erectile dysfunction. In the cytogenic erectile dysfunction, there is sudden onset. And then it is sporadic, it is younger, nocturnal, or AM erection is present. There is erection in AM. And in here, there is anxiety, depression, strained relationship, lack of sexual arousal, psychological disorder, and possible mechanisms include an imbalance of central neurotransmitters, over inhibition of spinal erection center by the brain, and sympathetic overreactivity. And this can lead to normal nocturnal penile tumescence and rigidity. This means that your penis will erect at nighttime or when you are sleeping. And then let's now go to the organic erectile dysfunction. In this organic erectile dysfunction, it is gradual and it is in all circumstances and can seen in older adults. Nocturnal or AM erection is absent. And there are 3 types of this organic erectile dysfunction. First thing is the vasculogenic erectile dysfunction. And this includes hypertension, smoking, hyperlipidemia, diabetes, cardiovascular disease, iatrogenic. That is why it's called vasculogenic erectile dysfunction. And another thing under organic erectile dysfunction is endocrinogenic erectile dysfunction. And this includes hypogonadism, and then hyperprolactinemia, hyperthyroidism, alcoholism, and iatrogenic. And then the third one is the neurogenic erectile dysfunction. This includes neurologic diseases, trauma, and then iatrogenic diabetes mellitus. Under this all that I have said, or the causes, this now this all will decrease the release of nitric oxide and cGMP levels. And the function of this nitric oxide is to activate relaxation of corporal cavernosal smooth muscle tissue, resulting in increased blood flow into the penis resulting in an erection. So kung mababa ang release ng nitric oxide, syempre makukulangan din ng blood flow sa penis. Meaning, meron na siyang, this can lead to erectile dysfunction now. Persistent or recurrent inability to achieve an erection. And then, this is the pathophysiology, and let's now go to the diagnostic test.
For the diagnostic test, we will do physical examination, obtain blood test, urine test, and ultrasound. We can also do psychosocial evaluation, neurological test to check for the nerve damage, and nocturnal penile tumescence, NPD test to determine kung anong naging cause ng erectile dysfunction. And for the medical intervention, meron tayong pharmacological therapy. Sa oral medication, meron tayo ditong sildenafil, vardenafil, tadalafil, and we have also here injection. And this is used to relax the smooth muscle, causing blood flow in the penis. We can also apply penile implant, a surgical implanted into corpus cavernosum. Then for the nursing intervention and action, during the consultation with the patient, the nurse should initiate a discussion of expectation and need of both the patient and his partner. It should also review both of the patient and the partner's understanding of PD and the result of diagnostic tests as well as providing an overview of treatment option.